Now we have a satellite symposium by AbbVie, so Dr. Osama Haji and Dr. Walid Hafiz, can you join us at the stage? For a closer look at the updated treatment of rheumatoid arthritis and axial spondyloarthritis.
Bismillah. Good morning. It's Friday morning, right? Everyone is asleep. I will try to wake myself and then you. But I think it will be a great session with dear colleague. The future of rheumatology is on the stage. So I'm proud to be with you. And آخر جمعة في شهر رجب بلغنا الله وإياكم شهر رمضان وجعل كل أيامنا عيد إن شاء الله. تفضل.
السلام عليكم ورحمة الله وبركاته. صباح الخير جميعا. جمعتكم مباركة, and I would really appreciate these beautiful words, Professor Haji. And I think I will try my best to keep the momentum and stand the same, level of excellence in presentation that you also, present. And I would like to thank colleagues from AbbVie for this kind invitation and helping us put the slide of this presentation together. So over the next 15 minutes at maximum, we will walk you through the latest trends that are, proposed in the management of both rheumatoid arthritis as well as axial spondyloarthritis. Professor Haji will start with a case, presentation that will bring the evidence and will link it to reality.
Yes, Mrs. Reem, the same height of me, 160 centimeter, slightly overweight. She's a smoker, she's diabetic, she has hypertensive, but everything, both of them are controlled. She's complaining of polyarthritis affecting mainly small joint of hands. Swollen joint is more than tender joint, and the patient is taking TNF for 1 year with weak or no response. And again, the patient is intolerant to methotrexate, complain of the weekly dose of methotrexate, responding on and off to non-steroidal and steroids. What is, if this is your patient, Dr. Walid, do you think, and she is a smoker, do you think that we have to change lifestyle or to think we are late to change the medication?
I think I agree with you, Prof. Both. It's important that this patient is not really achieving disease control, so part of it will be definitely related to the nature of the disease, but not to forget that the impact of the activity of the disease on the on the cardiovascular system in these patients as well. So I will walk you through another, patient. So we have Mr. Abdullah, who's a case of, axial spondyloarthritis, who's aged 43 years of age, and he works as a lawyer. He's maintaining like an ideal body weight, but unfortunately he's a smoker. And he has no family history of axial spondyloarthritis. He was diagnosed as a case of axial spondyloarthritis based on the classical inflammatory, low back pain, and that was coupled with elevated inflammatory markers. He also showed evidence of, bone marrow edema along with erosions on more than 2 consecutive, slices on MRI of the sacroiliac joint. And he was HLA-B27 negative. Now, he was only maintained on non-steroidal anti-inflammatory medications, so he is like, DMARDs naive, and he has what looks like, Crohn's disease as an extra musculoskeletal manifestations of axial spondyloarthritis. So how common, Prof, you see, patients with extra musculoskeletal manifestations in your cohort?
I believe that we have to start to treat our patient as early as we can. So I like the term undifferentiated spondyloarthritis, but I think axial manifestation is common, but we have to look especially if the patient has positive family history of IBD or psoriasis or previous attack of uveitis, but it's not common in Saudi Arabia, I think, in daily clinical practice without literature.
And it's worth to mention that this patient is having a severely active disease that's measured by ASDAS that is, calculated to be like 3.9. Okay.
Yes, this is a very interesting cohort study. and case control study that it's long enough to be respected in the history of rheumatology. It is 35 years with analysis. How much is the cardiovascular risk? If your patient die from rheumatoid, it will not be from joint. It will be mainly from cardiovascular risk. So we have to respect cardiovascular risk as it is 50% increase in comparison with the general population. Not only the whole cardiovascular effect, no. 59 is ischemic heart disease is increase in patient with rheumatoid arthritis, and 52% increase in cerebrovascular disease. Why this? Because of the low-grade inflammation. Low-grade inflammation can affect the endo and EP. I like endovascular, vascular cell. That's why controlling of inflammation, it will be a good impact to your patient in daily clinical practice. Yes, that's why we have to take care. I like the term holistic approach of treatment of rheumatoid arthritis. We should go outside the joint. We should take care about the patient as a whole project. Controlling inflammation, yes. Controlling disease activity, yes. But holistic approach is very important, as we said, that controlling low-grade inflammation, it will affect the cardiovascular risk, it will be decreased. And again, the second most important, socioeconomic and the quality of the life of the patient. The third, that cancer. Your patient is with low disease activity or sustained low-grade inflammation, liability to be in lymphoma is increased. That's why increasing disease activity, it will be high impact to the patient. Again, if you are depending on the steroid, your patient may suffer from osteoporosis and osteoporosis-related fracture, and the most important, that infection. That's why going back to Reem, that she is diabetic. If you are increasing steroid, it will affect diabetes, and your patient will be liable in post-menopausal to be post-menopausal osteoporosis, and again, steroid-induced osteoporosis. That's why you have to see the whole picture of the patient, not only to treat the joints.
Yes.
Again, this is very important that I like this term, treat to target. I believe in window of opportunity. What does it mean? In rheumatoid arthritis, according to ACR EULAR criteria, if your patient has 6 weeks of arthritis, we can diagnose the patient? Yes, provided that he has no other diagnosis. I believe in window of opportunity, that you have to treat your patient as early as you can, not only like this, and you have to achieve remission or low disease activity. If your patient is controlled in a good way as early as you can, the liability or the chance to be a low disease activity or sustained remission is higher if we start early. That's why ACR, EULAR, all international guidelines aim to treat to target, provided that we are using a proper target to treat our patient with.
Yeah, thank you, Professor. However, despite all the advances that we have, in the understanding of these inflammatory arthropathies, plus the medications that we have so far, unfortunately, a good percentage of our patients do not yet, achieve remission. Now, if you follow this bar chart, and if you focus on the chart that is colored, or the bar that is colored by gold, you will see that approximately, 53% of patients, achieve like a momentary or like a temporary remission. And if you talk about the sustained remission, this percentage goes further down to only, 17%. So you have a good, and respectable amount of your patient who do not, achieve either, like a momentary or like sustained remission, despite, having all these advances. Now, is, achieving remission important? Yes, because achieving remission is actually linked to the reduction and delaying in the radiographic progression in patients with axial spondyloarthritis. The higher the disease activity that is measured by ASDAS, and it's actually represented in the right, curve graph by circles, the more the changes that we will having in the radiographic, assessment that is again measured by the MSAS. Now the lower the disease activity, that is again measured by the ASDAS. So for example, if you have a disease activity of less than 1.3 measured by ASDAS, that is actually linked to inactive or actually inhibition of the radiographic progression in patients with axial spondyloarthritis.
Dr. Walid, do you think that Mr. Abdullah, your patient, is belong to high disease activity as DAS is high and the patient has bone marrow edema and he is complaining of pain? So the liability to be in a radiographic progression, keeping in mind his male is high, that's why we have to be
high. Yes, Professor. And as you mentioned, and as you saw that, despite that the patient was achieving kind of like ideal body weight, and the only fact that he was a smoker, but he was showing erosive changes on MRI that is really an indicative of a patient that is going to progress faster if we do not achieve like the treat to target aspect or in this patient. Now, remission and improving the radiographic progression is not only the target. Unfortunately, patients continue to have symptomatology despite receiving again treatment with the different disease-modifying anti-rheumatic medications. And if you look at the ASAS Health Index, approximately 78% of our patients report pain to be the highest component when it comes to the ASAS health, and approximately more than a third of our patients, despite receiving like a TNF-alpha inhibitor therapy, continue to suffer from like pain. And I think, Prof, it's not only related to the pain that is secondary to the inflammation. What is your insight about the different mechanistic pathways of pain in patients with axial spondyloarthritis?
I believe in the term neuroplasticity. This is a very important term, again, in rheumatoid, in SLE, or any patient. Even in SLE, there is type 1 and type 2. The issue is that if you are not controlling inflammation in the window of opportunity, the patient will be shifted from nociceptive pain related to inflammation to be a central pain related to neuroplasticity. Whatever you're controlling inflammation, the pain is there, so we have to start early and aggressively control inflammation before we are shifting to duloxetine or any treatment for neuroplastic. So totally agree with you.
Wonderful. So the mic is yours.
Yes, we have an issue. I like to term, but I like to be my own term. The first term is cycling. Cycling, it means you are shifting between 5 TNF, who are lucky generation. Our professor, Allah yarhamhum ahya'an wa amwatan, they are teach us, but they have no option. Now we have 5 TNF, we have 5 IL-6, and we have a lot of medication. Even with JAK, we have 3 in Saudi Arabia. Which one will you choose? Cycling means if you are shifting between different TNF, it means you are giving chance of 3 to 6 months. Between 5 TNF, you will take about 2 years. If you are using IL-6, you will taking long time. Remember, we said that we have a window of opportunity we have to control. Switching, if the patient not responding to the first one, we have to shift to another mechanism of action. Guidelines is not clear or giving conditionally recommending like ACR. What ACR say? Conditionally recommended, not strong, but if the patient not responding to one of the class of medication, shifting to another mechanism of action is advisable. EULAR, make it open. You know that EULAR is making the cost to be considered in the treatment. That's why if the patient not responding. But I don't like the left lower one, which is difficult to treat. By definition, if the patient not responding to 2 TNF or other two biological agent, the patient will be difficult to treat. So proper choosing the proper medication to the patient to achieve early remission, this is a very important. And I am advising junior colleague to think how I will treat this patient for the next 10 years. I will start with TNF, what's the next? I will start by JAK, what's the next? And we have to make in mind that we have to individualize the treatment to each patient separately, but we don't like to reach difficult to treat rheumatoid arthritis.
So if we have some, insights from the audience here, so please raise your hands if you cycle the treatment with another TNF-alpha inhibitor if you have a failure of one TNF-alpha inhibitor? Please raise your hand. So we
Who's
have
making-
a few.
Who is making cycling? Yes.
So we have like few who actually cycle the treatment. How about switch? So if you have a primary failure, for one of the TNF-alpha inhibitors, do you cycle or switch? So we have like...
I'm included, right?
Of course. Okay, wonderful. So let's move on. Again, the slide with you, Prof.
Yeah. This is not right and wrong answer. This is the art of rheumatology. This is the art of treating rheumatoid arthritis. That's your sense to judge your patient in a good way. This is the beauty of our daily clinical practice. Again, this is a very important publication published in 2016, although it is old, but something interesting. It is a French. If the patient not responding to TNF, what is the option at that time? Shifting to abatacept, to silizumab, or another TNF. What they found, the odds ratio of achieving remission or low disease activity is 2.5. 2.5. Your chance to achieve low disease activity or remission is higher if you are shifting to another mechanism of action. If you are looking here, you will see that within 1 year, it is nearly double. If your patient shifting to TNF, another 23 will be 41, nearly double. If your patient shifting 14%, it will be 27. So the chance is doubling if you are shifting to another mechanism of action. That's why I myself believe in switching, not in cycling. What about you, Dr. Walid?
Yeah, it's the same. Switching is actually rather for me than cycling.
This is included in JAK, right?
Yes, of
So
course.
if the patient not responding to the first JAK, yes, there is still liability to respond to another JAK, but shifting to another mechanism of
Yeah.
action is a good
And
option.
I think more data is needed. Now, as warned by the time, keeper, that we have only 5 minutes, so I think we will try to,
We will be.
move faster.
Yes. The point is, this is the most important slide. I call it difficult to treat. The patient who failed TNF. What's the option for all JAK? The first one, tofacitinib, and the second one is Bari. The third one is UPA, and 3 of them in comparison with placebo. The achievement, this is not head-to-head clinical trial, just that's the number for comparison. If you concentrate on the Bari and UPA, you can see that numerically the achievement select beyond. This is a patient who failed biological therapy, TNF, and receiving UPA 15 or 30, but this is not recommended or not included for rheumatoid arthritis. The chance of achieving is higher even after failure. But I myself believe in early start, like start mono, start elo, start Lex. This will be much better. The figure will be higher. Further?
Yes, thank you.
Yes, this is a very important. This is not to head-to-head clinical trial, but this is our daily clinical practice. If the patient starts UPA and responding, the patient will have a sustained response for 5 years. This is the upper one curve, the green. If your patient is responding to adalimumab, it will be immediate and will be sustained. But in the original clinical trial, there is significant difference and early achievement of low disease activity and remission with UPA in comparison with adalimumab. The point here, they are making in the design of the clinical trial, this is post-hoc analysis, rescue. What if the patient is not responding after 14? After 20, after 24, after 28 weeks to UPA, the patient is shifting immediately to adalimumab. If the patient not responding to adalimumab, shifting to upadacitinib. What's UPA? Is very interesting, the red one. The red one, the patient is shifting from upadacitinib not responding to adalimumab. And the most interesting for me that this is the placebo to the gray one, and the most important, the green is shifting. Still, there is a chance if the patient not responding to adalimumab, shifting to upadacitinib, there is a chance of improving and achieving. On your left-hand side, achieving remission. On your right-hand side, low disease activity. So it's very important still, if your patient within 3 months not responding to any mechanism of action, shifting immediately to another one. Are you doing this in daily clinical practice?
Yes, certainly.
Yes, but you like to start with TNF or JAK?
I mean,
Yeah,
so
difficult.
again, there are many factors. So patient, preferences. Other extra musculoskeletal manifestations that are, there in the patient. So these are kind of like,
دكتورة منال بتقول
shared
لك فاضل 10
question.
دقايق.
Okay, so 10 minutes. خلص. Okay,
That's-
so we'll walk you quickly through. JAK inhibitors made their position in the guidelines, as you can see that, and patients who received upadacitinib in, biologic naive patients for approximately 2 years, you can see that in the right upper corner that approximately 86% of patients received, low disease activity measured by ASDAS, and approximately, 45% of patients received like low disease activity again, or inactive disease measured by ASDAS. Again, pain, regardless of the type of the pain, so be it a back pain or peripheral pain. Again, patients who were started on placebo showed some differences compared to, upadacitinib in terms of response to pain. But then once these patients switched to upadacitinib, they picked up the pace and were showing significant responses in terms of like pain improvement. Furthermore, we were talking earlier about the radiographic progression. Again, patients who were shifted from placebo to upadacitinib showed, reduction in the radiographic progression in patients with axial spondyloarthritis. How about patients who do not, show adequate response to TNF-alpha inhibitors at the beginning? These patients, once they are, changed or switched to a mechanism of action that is different to a TNF-alpha, such as, for example, interleukin antagonist, approximately 25% of patients, show or achieve low disease activity. On the other hand, patients who do not achieve remission on, biological DMARDs, when they're switched to JAK inhibitors, approximately 56% of these patients receive, remission. How about extra musculoskeletal manifestations such as IBD? So it was noted that patients who were on upadacitinib, they did not have an increased risk of IBD compared to placebo. And again, on the other hand, patients who were on placebo had numerically higher, incidence of uveitis compared to those who were on upadacitinib.
So in the previous slide, that I still believe that undifferentiated or early axial spondyloarthritis. So if I'm scared that this patient will develop later on uveitis or develop the IBD like your patient, he has a manifestation question mark of Crohn's disease. Do you think that JAK, upadacitinib, will be a good option if your patient taking whatever track the JAK, UPA will cover all scenarios?
Certainly. And we're all aware that now, upadacitinib was approved for, IBD, as an indication. And we're waiting for uveitis again to be, an indication for the management in these patients. How about,
Yes.
safety?
Going back to Reem, I'm not scared. 1 minute only. One. Count from 1 to
30
160.
seconds and that's it.
Yes. From cardiovascular risk is very important for me, and we have to save our life of the patient as much as we can. But being a diabetic or hypertensive control, this is not the issue. If the patient has atherosclerotic cardiovascular disease, atherosclerotic confirmed cardiovascular disease, if your patient is smoking, if your patient is 65 and more, JAK is not suitable one. But for the program of all select, I am believe in methotrexate, but it's not indicated. Early step beyond, compare all this, the risk is nearly identical to TNF or any other biological therapy except herpes zoster. And for me, herpes zoster, yes, it is a weak point for JAK, but again, a strong point for JAK. If you are immunizing your patient with the vaccine, it will be a good option for your patient. If you stop JAK for 1 week and then vaccinate your patient, stop 1 week and then restart, it will be a good option. Even by SCR recommendation, it is a good option that you continue same medication and vaccinate your patient for herpes zoster. We are not doing, we are in the private sector, but still your patient is favoring oral. This is true
it's the same as noted, regardless, like in the Saudi database as well as, in the American study.
Time is done.
So the last slide.
Yes, going back to Reem and Abdullah, which was me and Dr. Walid, that JAK, upadacitinib is a good option for this patient, and thank you for your time and attention.
And ladies and gentlemen, this was a scientific song titled RA and Axial Spondyloarthritis that was presented by the duo of Professor Haji and Walid Hafiz, sponsored by AbbVie. Thank you very much.